Welcome to our first session in the leadership track titled What House Resolution 1 Means for Medicaid in Ohio. And it seems like never before has there been such a heightened awareness for the legislation and the policy that's coming out of Washington at the federal level. And of course, that concern always means that there'll be an impact on the state and a lot of discussion about how some of these federal issues will impact state legislation. And of course, maybe what's most important to all of us in this room, as you know how the saying goes, things trickle downhill. Usually the policies that are adapted and adopted at the state level eventually trickle down to all of us at the county level. So we have a great interest in what all that means as we all try to navigate and strategically plan for the future. So discussing the impact on the One Big Beautiful Bill are Amy Rowling McGee, President of Health Policy Institute of Ohio, and Brian O'Rourke, Healthcare Policy Analyst with Health Policy Institute of Ohio. And since 2003, HPIO has focused on studying and influencing public policy discussions that lead to improved health value, especially to those that emphasize diverse, inclusive, and accessible environments for all Ohioans. So without any further introduction, please join me with a warm welcome for Amy and Brian.
Thank you, John, and thank you to the Ohio Association of County Boards for inviting Brian and I to be with you today. I'm going to start by sharing a little bit more information about the Health Policy Institute of Ohio. Out of curiosity, I'm wondering how many of you have heard of HPIO before? Good, okay, wonderful. So we are a small-ish nonprofit organization based here in Columbus, but serving the entire state of Ohio. Our vision is that every Ohioan reaches their full health potential. And our mission is to inform data-driven policymaking that improves health, health equity, and healthcare spending here in our state. We are able to pursue that mission because of the funding we receive from our philanthropic partners throughout the state. We have a kind of interesting origin story in that it was a group of foundations that came together to create us back in 2003. And their continued support and investment in our work enables us to produce the kind of analysis that Brian and I are going to share with you today. We're going to start at a really high level, give you a high level picture of what healthcare access looks like in our state, what healthcare affordability looks at in our state, and then the Medicaid program overall, before we get into the very nitty-gritty nuances of implementation of HR 1, otherwise known as the One Big Beautiful Bill Act. So just starting at that high level, from 2010 to 2022, Ohio's uninsured rate for people under the age of 65 dropped in half. This was primarily due to the Affordable Care Act and the Medicaid expansion that Ohio decided to implement in 2014. So with those new Medicaid eligibility levels and to a smaller extent, the health insurance marketplace, we saw a dramatic reduction in our uninsured rate here in Ohio. Now, that uninsured and insured rate has started to tick back up over the last couple of years, and it's expected to continue to increase over the coming years because of recent policy changes, including those that were a part of HR 1. Even with our relatively low uninsured rate, though, we know that about 1 in 5 Ohioans still have trouble affording medical care. So uninsured Ohioans are more likely to struggle with medical bills, with 33% having trouble paying off their bills in 2023. However, even people who are covered through their employer insurance also frequently have trouble paying off their bills. And maybe this is a pressure that you have either personally experienced or you have family members who have experienced. And a lot of companies there's been increases in deductibles that need to be met, and also increases in premiums, health insurance premiums that need to be paid. Employers, especially small businesses, are having a harder time absorbing those costs and maybe passing some of that along to their employees, even if they very much value health insurance and want their employees to be covered. So what that means is that out-of-pocket spending on things like employee share of premiums and payments made before deductibles are reached is higher in Ohio than in the United States. Premiums for an employer-sponsored plan in Ohio are on average $1,791 for an individual and over $6,000 for a family plan. So for a family with limited means, a modest income, and those can be challenging expenses to absorb. To put a little more context around that, a family of 4 in Ohio with 2 children using childcare needs to earn over $79,000 a year to be able to afford healthcare and other basic essentials. And that's data that comes from a tool created by United Way nationally called ALICE. So we use this as an example of how much it truly means to make how much you truly need to earn in order to make ends meet, because we know that the federal poverty level is very, very low, and very few people could make ends meet with just income that's at the federal poverty level. This amount, though, varies by county, so important to recognize that. Cost of living may be more expensive in some parts of the state than other parts of the state. And then, of course, healthcare and other expenses may vary based on circumstances in your family. So this is just kind of an average, but if you have somebody in your family that has more complex medical needs, is requiring more care, that amount could be exponentially larger. Medicaid was created in 1965 by the federal government to pay for medical care. So it was created at the same time as Medicare. Medicare is a pretty much universal program that everyone over the age of 65 has access to, whereas Medicaid is a state-federal partnership and is means tested, so it's not available to everyone. Today, the Medicaid program pays for care for people with low incomes, including children and families, older adults, and people with disabilities. Nearly 3 million people, or about a quarter of Ohio's population, has Medicaid coverage. It's a partnership between the state and federal government, with some of the funding coming from the federal government and then some of the funding coming from within the state. Now, not all of it is coming from state GRF, as you are well aware. Some of it is coming from the local level or some other sources. But to simplify it, there's state or local level funding and there's federal funding that enables the Medicaid program to continue. In state fiscal year 2025, Ohio Medicaid spending totaled $43.2 billion. The federal government paid nearly $30 billion of that total. State GRF paid $7.8 billion of the total. And then non-GRF state funds, which includes state match funded by county boards, totaled $5.8 billion. Today, the Medicaid program pays for Oh, I already said that part, sorry. The majority of people with Medicaid coverage are in the covered children and families category. About 708,000 people with Medicaid coverage are in the Medicaid expansion coverage. And again, that was the newly eligible people that gained coverage back in 2014. They're sometimes referred to as Group 8 as well. So at some points in our presentation, we may use Medicaid expansion population. In other parts, we might say Group 8 population. So 708,000 Ohioans in that group. And then there are about 507,000 people who are in the aged, blind, or disabled category, also known as the ABD population. This is a very high-level picture of Medicaid eligibility levels here in Ohio. So of course, it doesn't capture all of the various nuances of Medicaid eligibility, but is meant to give a general sense of what are some of those criteria that a person needs to meet in order to receive coverage through Medicaid. This slide is particularly focused on the expansion population. So the people with incomes up to 138% of the federal poverty level are eligible for expansion coverage. Again, that's currently 708,000 Ohioans get coverage through that group. To give a sense of what it means to be at 138% of the federal poverty level, we show these examples of families, individuals or families, and the types of jobs they could be employed in and be not and still qualify for Medicaid expansion coverage. So one that's particularly relevant to today's conversation is that you could have a parent with a child, so a two-person family, and they could earn no more than $29,187, which is a typical wage for somebody just starting off in the field of home health or personal care, aides or assistants, people who work in administrative assistant jobs, and people who are sales associates. And importantly, those types of jobs are less likely to have health insurance offered through the employer. And that could be for a variety of reasons. One, there could be no insurance offered, or it could only be offered to people who are working full-time versus part-time. Person may be only able to work part-time, or maybe they're working several part-time jobs, none of which qualify them for their employer-sponsored health insurance. Also, another important consideration is that going back to the premium contributions and the deductibles that more employers are needing to pass along to their employees, a person could have an offer of health insurance, but not be able to afford it based on their wages because their contribution to the premium could be so great that they wouldn't be able to make ends meet and pay for other expenses in their family. So having Medicaid expansion coverage has been very helpful for people who work in these types of positions throughout our state. Going back to the federal contribution to our state's Medicaid program. So the amount that the federal government contributes is known as the federal match, or sometimes the FMAP. That totaled, again, $30 billion in state fiscal year 2025. The rate at which the federal government pays for Medicaid services in a state varies by the types of expenses or services. The Medicaid expansion population has a higher match rate associated with it than for the other categories of Medicaid eligibility. And it's been right around 90%, or it's been at 90% for a number of years. There was a provision that you might have heard about in the state budget bill that was indeed in the past version of the state budget that mandated that if that match rate drops below 90%, then the Medicaid program for that expansion group will cease to exist. Now, at this point in time, there have been no policy changes at the federal level, nothing included in HR 1, nothing included in any other bills that have passed since that has reduced the FMAP for the expansion population. So this population will continue to exist, at least for now, here in the state of Ohio. However, there's other pressures on the state Medicaid program that Brian and I are going to describe that could also end up impacting Medicaid eligibility here in the state of Ohio. But for now, this is all remaining the same, like this whole graphic here. And that includes the match rate for the state waiver programs, which I know you're very familiar with. Right now, there are about 46,000 people with waivers administered by DODD. And while the legislation that I've described, HR 1, doesn't directly impact those waivers, there's many ways in which it will impact Ohio's Medicaid program overall and may impact the DD system, as John alluded to in his introductory remarks. In addition, there's other state level pressures that could also impact the state Medicaid program and then also the system as well. Here are some of those pressures, likely not an exhaustive list. We're going to spend the rest of our time talking about the very last one, which is the HR 1 policy changes. But the others that we at least just wanted to mention, healthcare spending overall, like per capita overall and within our state, is trending in the direction that we would not like for it to be trending. It's going up. And because of that, like state Medicaid costs are also rising. So that's going to be a pressure that we're all going to need to continue to grapple with. Brian's going to mention a publication that HPIO puts out every 2 years. Well, I guess I'll go ahead and mention it right now. It's our health value dashboard. We just put out the 2026 health value dashboard. It's a collection of over 120 metrics related to population health here in Ohio and healthcare spending in Ohio. Ohio does not perform well on either of those categories. And then we also look at all of the systems and environments that impact our health as well. And on most of those, we're not performing well either. We do relatively well on access to care, but on metrics related to our healthcare system performance, our social and economic environment, our physical environment, we are not performing well. So, there's many factors that are driving poor health outcomes and higher healthcare spending. But one is that all of these factors and environments also need greater attention. Access to care is necessary but not sufficient to getting to good overall health. It's super important if you're sick, if you have an accident or injury, if you're dealing with a chronic health condition. However, having access to care is only one part of getting us to overall health. So if you want more information about that and around healthcare spending, please look at our health value dashboard. We also know that our revenue base and our tax base is either already limited or there's threats to it, like the property tax issue, for example. So definitely important issues for us to be paying attention to. And then there's also a very intense focus on waste, fraud, and abuse in the Medicaid program and the overall integrity of the program. That is getting a lot of policymaker attention right now here in our state and at the federal level. So another issue to pay attention to. But for today, we're going to focus on HR 1. This was a very early estimate of what the financial impact and the coverage impact of HR 1 could be on the state of Ohio. So this came out, I think, right around the passage of the law back in January of 2025. And these researchers found that Ohio would lose about $33 billion over the next 10 years in federal funding in the form of that federal match that I talked about earlier over the course of that time frame. And around 340,000 Ohioans would no longer have coverage. There are some that believe that these estimates are on the low end, which could be true. But we will share with you today the analysis that we have done to kind of add more specific detail to how this bill will impact Ohio and what decisions are before our state policymakers here as we work on implementation of this federal law. So I'm going to hand it off to Brian. Oh no, I'm doing work requirements. Sorry. Okay. I forgot. All right. We are now going to turn our attention to some of the changes. Now, this is before we get to the financial implications of HR 1. So one of the implications that will impact the workforce in general and may impact people who have IDD are the work requirements. So the federal law mandates work requirements for everyone in the expansion population. We know that there are some people who are in the expansion population, of that 708,000 Ohioans that have that coverage, who may have some form of disability. It was a more streamlined path to eligibility for people to get their coverage through the Medicaid expansion group versus going through the lengthy process to get coverage through ABD. So there could be people, well, we know there are people with, say, mental health or substance use disorders who could potentially qualify under ABD, but were enrolled under Medicaid expansion. Likewise, there could be people with IDD who are also enrolled in Medicaid expansion because that was a kind of more expeditious pathway to get coverage. These work requirements will apply to people who have expansion coverage unless they meet some exemptions. They'll need to work 80 hours per month or be in an educational program or engaged in some form of community service or a combination of all of these. Again, there will be exemptions for some people, especially for people with medical conditions. And then also, these are, I'm going to talk a little bit more about the time frame, but just so you know, we had already submitted a waiver for to implement work requirements here in our state, even before the federal law passed. There were differences, though, in what our state submitted and was required to submit by our legislature and what is in the federal law. So the Ohio Department of Medicaid has been going kind of back and forth with the federal government, figuring out the nuances of how Ohio will implement these requirements, kind of based on what we already submitted and then based on what the federal law said. The Ohio Department of Medicaid has estimated that about 77.7% of people who are in the Group 8 population will meet those statutory requirements. And they're able to know that because of ex parte processes. So they can kind of ping a variety of databases and gather enough information to know that roughly this percentage of people will meet the requirements and may not need any additional assessment from their county Department of Job and Family Services. However, there will be about 22% of those in this group who will need some additional assessment. And that's where there's some concern about people potentially falling through the cracks. At the same time that this provision will be implemented here in our state, we will also be implementing another provision of H.R. 1, which is redetermination for Medicaid coverage for the expansion population happening every 6 months versus every 12 months. So that's kind of double the workload for county departments of job and family services. It's more bureaucracy and hoops that people will need to jump through in order to be able to demonstrate that they're still eligible for the coverage. So even though it's likely, around a quarter of the population who will need to jump through those hoops, it's still a substantial number of people who will be going through those more hands-on kind of processes. And if there's a lot going on in their lives, if they've moved, if they are having difficulty navigating that system in any way, shape, or form, they could potentially lose coverage. These are some of the types of medical exemptions that are laid out in the law, the federal law. We don't yet know the specifics of how, like the types of documentation that will be required to prove that you meet any of these categories on this list. The federal government is supposed to be releasing rules for the implementation of work requirements in the next few weeks. And so we'll learn more about what kind of verification will be required. The states are required to implement work requirements by January 1, 2027, unless they ask for an extension. And Ohio has said they don't plan to ask for an extension. So Ohio will need to start notifying people here in September of 2026 about their, like, what's happening, what the process will look like, what they need to provide. So we'll be hearing a lot more about this here in the next few months and how this will be implemented in our state. And now I will hand it off to Brian to talk about the financing changes. Okay.
Okay, we can hear me. Hopefully I won't yell too much. Hi, everyone. I'm Brian O'Rourke. I'm a healthcare policy analyst here at HPIO. I've been working a lot on issues related to the healthcare system, healthcare spending, and very prominently how HR 1 is affecting our health programs, including, as you might already expect, Medicaid being really the main health program that needs a lot of attention right now in Ohio. I'm going to try to give you a high level of a couple more provisions that directly affect enrollees, and then I'm going to move into the financing changes. I really do want to leave like 12 minutes for questions at the end, so I might go a little higher level than anticipated, which is probably a boon for you all. But if you do really want to get into the nitty-gritty details at some point of the financing changes and the exact impacts, we do have a brief on that on our website, which will have a link later on, and I'm also happy to take questions on specifics as well. But I'm going to start specifically with two more provisions that are a little more enrollee focused before getting into the budgetary content. So still focused on that Medicaid expansion population, we know that H.R. 1 is going to require that states impose mandatory cost sharing of up to $35 per service. Again, just for the Medicaid expansion population, with some exemptions for substance use disorder treatment, primary care, mental health services, which is not exactly clear yet. This is a concern because KFF estimates that this could cost some enrollees over $500 a year, which in a generally low income population is obviously a potential threat to overall financial vulnerability, things like medical debt, et cetera. We also know that in 2023, 52% of Medicaid enrollees in Ohio reported difficulty already paying household expenses like healthcare, food, and housing. This is an important area where Ohio needs to make a decision too, because the federal law just says up to $35 per service, but obviously there's a lot of space between 1 cent and $35. And then one last enrollee-focused provision in H.R. 1 is major changes to eligibility for immigrant populations who are lawfully present and previously had access to health programs like Medicaid. So we're going to see many groups of non-citizens who are lawfully present, including refugees, asylees, survivors of domestic violence and human trafficking, and people with temporary protected status, lose access to Medicaid starting in October of this year. And these were groups that previously could access the program. This is not restricted to the Medicaid expansion population. This is for Medicaid overall, and it also aligns with provisions that affect Medicare, the Affordable Care Act marketplace, and the Supplemental Nutrition Assistance Program. Now, the provisions are different across the program, so there's differing timelines and eligibility, but this is a real narrowing in some of our immigrant populations in Ohio who could previously access these health programs. So now I'm going to go into financing changes, which I think are some of the most overarching and impactful changes to Medicaid, especially here in Ohio. We have three kind of major, I think, financing provisions that I want to talk about. The first is restrictions to something called provider taxes, which are a way that Ohio and a lot of other states generate revenue for their Medicaid programs to improve care access and pursue certain care initiatives. We're also going to see that H.R. 1 caps state-directed payments, which are one way that Ohio uses provider tax revenue to help boost payments to providers who see a lot of Medicaid patients in the state and help support their sort of financial condition. And then you've probably heard about, but I'm not going to talk as much about, the Rural Health Transformation Program. So this is a one-time $50 billion funding source. So each state is going to get about $1 billion over the next 5 years, which is designed to pursue rural health innovations to improve care access and rural health and align with certain administration initiatives. The only part I really want to emphasize here is that while this funding will probably produce some really interesting and cool projects for rural health here in the state, it is not designed, and it numerically cannot account for the losses that we're going to see due to the other financing restrictions. And that is sometimes how it's talked about in some of our public and political discourse that we've seen. So let's start with provider taxes. I had mentioned these are essentially taxes or assessments on different healthcare entities like nursing homes, hospitals, or insurers that states use to generate funding for their Medicaid programs. So every state except for Alaska has at least one provider tax. They draw down federal matching funds when they are or matching federal funds when they are used for Medicaid initiatives. So that really helps support program stability, especially in economic downturns, for example. And currently, Ohio has 4 provider taxes. We have them on nursing homes, hospitals, insurers, and intermediate care facilities for people with intellectual disabilities. I'm going to mostly talk about the 2 provider taxes in the middle, which are hospitals and insurers, because that's where the provisions are mainly impactful. And I think an overall takeaway throughout this section on provider taxes is that these changes really do threaten the overall kind of financial stability of Medicaid programs and aren't isolated to specific categories or groups within Medicaid. And we need to see how it plays out, how the state is responding if the state is taking certain decisions or making certain decisions to actually mitigate some of these funding losses, which I'll allude to as well. These are all things to be keeping in mind. So the three big changes to provider taxes are prohibiting any new or increased provider taxes upon enactment of H.R. 1 last July. It restricts waivers for certain kinds of provider taxes that didn't technically meet federal requirements, which does affect Ohio specifically. I'll talk about that more in a second. And then it also is going to gradually lower what we can consider the maximum allowable tax rate. So in other words, the maximum amount of revenue that these provider taxes can bring in for states starting next year as well. And I want to emphasize one more point, which when you hear provider taxes, that sounds like something providers really wouldn't like. That is not the case. Providers are generally supportive of these provider taxes because they help ensure people have insurance when they come to get care, which reduces uncompensated care costs, and it can help them pursue, care access initiatives that improve care quality and boost reimbursement to providers specifically. So the two provider taxes I want to talk about specifically are first our provider tax on health insurers, which is called the HIC franchise fee. You don't need to remember that. Right now, the HIC franchise fee has a different tax rate for our Medicaid managed care organizations than other health insurers in the state. That technically violates the federal requirements for provider taxes, but since 2017, the Centers for Medicare and Medicaid Services has given us a waiver to allow us to use the tax in this manner. And what you'll see is that this tax brings in billions of dollars in revenue for the state. So there is a decline in sort of the anticipated revenue for the next 2 years because Medicaid enrollment is dropping right now. But nonetheless, we're looking at about $1 billion of state revenue per year from this tax with an additional about $2 to $2.5 billion in federal funding. Now, because of the provisions in H.R. 1, the HIC franchise fee needs to either be modified to make that tax rate uniform, or it's going to be eliminated entirely in July 2027. So this is a big deal, and this is an area, like I had alluded to, where Ohio can take specific action to mitigate the full extent of these funding losses and not have to start thinking about much harder decisions related to cutting expenditures, for example. The Ohio Department of Medicaid is estimating that this will ascend if no action is taken and the tax is just eliminated next July. This would cost the state about $2 billion every year. So this would be $2 billion in funding loss per year between state and matching federal dollars. Now, of course, like I had mentioned, the tax can just be modified to make a uniform tax rate across all health insurers in the state, and we would not see this extent of losses and could potentially recoup up to all of that money and not see it as losses to our Medicaid program funding. The hospital franchise fee is the other tax I want to talk about briefly. So this is a tax on hospitals. It's currently assessed uniformly as a percent of their total facility costs. So there's no issues there with the waiver or anything. But because of what the tax level currently is at, when we think about that gradual phase down of the maximum allowable tax limit, we're going to see the revenues from this provider tax also decrease in coming years. So what you can see is the hospital franchise fee brings even more revenue for the state. We also just recently increased it right before H.R. 1 passed. So this is like really the last increase to provider tax we'll see until essentially federal policy changes. And in state fiscal year 2027, we're starting to see $10 billion in all-fund impact or all-fund revenue for the state Medicaid program from this provider tax. So as I had mentioned, starting in October 2027, there's going to be a phase down of that maximum allowable tax rate, also called the safe harbor limit. And so we're going to see revenues from this tax decline gradually over time. Now, it's not like a full elimination as we saw with the HIC franchise fee, and it's much more gradual over 5 years, basically, starting at the end of next year. Nonetheless, ODM is estimating an annual loss of somewhere between $730 to $930 million for the state, which is again another source of revenue that will need to be made up for in future years. But it's a little more long run. It is a little more gradual, as opposed to the tax on health insurers, where more immediate state action is necessary to prevent the elimination of that revenue source. One more financing mechanism I just want to talk about briefly, and then I'm going to do some big picture work if you're not as into all of the numbers I just threw at you, is state-directed payments. I had mentioned this is something that a lot of states use to essentially enhance provider payments and support care quality initiatives in the state. So we have, I think, 26 SDPs in total. Our hospital additional payments SDP, for example, boosts payments for hospitals around the state that care for Medicaid patients. We have SDPs that help us perform new innovative quality improvement mechanisms for low-income populations in the state, things like that. And HR 1 is going to put a cap on how much those provider payments can be boosted in the future. Right now, we can boost payment rates to the commercial reimbursement level. That's going to drop down to the Medicare reimbursement level, both of which are still higher than typical Medicaid payment rates, but it is going to be a decrease for providers. And ODM suggests that this is going to cost providers around Ohio, so not the state, about $200 million annually. Okay, so you can see from this timeline that some of these provisions went into effect right away. And then we have big decisions on the horizon. The first is that health insurance franchise fee and resolving the non-uniform tax. And then we'll start to see the phase down issues with provider taxes and then the payment ceiling on SDPs. What I think is the most important part of all of this is thinking about what does the state need to do, what's important to be keeping an eye on. The three sort of areas we want to highlight are first, mitigating resolvable funding losses. So this is really that health insurance provider tax. We don't have to just accept that $2 billion annual loss, which would be a major dent in Ohio's Medicaid budget. And we have till July 2027 to address that. States can also identify new revenue sources where possible. Of course, that comes with its own set of political considerations, but it is an important thing to keep in mind. And then the last part is, I think, just really careful consideration of the consequences of cutting Medicaid expenditures. I think we can all envision how that could affect people currently enrolled on Medicaid. We will see people lose their insurance potentially. We will see increased financial vulnerability, issues with our workforce and workforce productivity. But it's also important to emphasize that there are broader impacts to Ohio's healthcare system infrastructure that need to be considered as well. I'm going to touch on those in a second. Some types of Medicaid cuts that we could see or that other states have pursued. One is reducing provider reimbursement rates. States like North Carolina have already started to enact provider rate cuts. Ohio just recently, a couple years ago, passed a large set of provider rate increases for home and community-based services specifically, which I think you're all aware of. And part of those rate increases are actually funded by the hospital franchise fee revenues going forward. So that's just something to keep in mind. But we all can, I think, envision what the consequences of reducing provider reimbursement rates are, especially with how low Medicaid reimbursement can be. We're going to see increased strain potentially on our providers if this was pursued, and obviously big care access issues for our populations. Medicaid has a lot of services that are technically optional. Ohio offers a lot of those, which is great. It's a pretty comprehensive Medicaid program. This includes prescription drugs, vision and dental services, a lot of home and community-based services, mental health and behavioral health supports that are technically not required by CMS. If this is sort of an area where cuts were considered, again, I think we can really easily envision the consequences for Medicaid enrollees, increased financial vulnerability, potential higher out-of-pocket costs, things like medical debt, all sorts of issues like that. And then last, some states might consider restricting eligibility groups. So Medicaid expansion, for example, is an optional eligibility group. But if we do see our uninsured rate kind of rise consistently because we are cutting people off of Medicaid, that can have cascading effects around the system. It increases uncompensated care for providers, which puts more strain on them. We could see hospital closures in rural areas, for example. We could see just care access issues for all kinds of providers. I would think about workforce productivity issues like that, and then potentially what we call spillover effects, which is higher healthcare prices across the entire state when a lot of people lose insurance, even for people who still have their insurance. I'm going to skip that one and go right into conclusions and then just share a few resources so we can at least have about 10 minutes for questions. So I think the really big picture things to think about here is first that HR 1 is going to have large impacts on Medicaid eligibility and financing. We don't exactly know how all of this will play out. We don't know what types of, for example, types of services or provider reimbursement rates, like where people might look. But it is just something to be really aware of and to be watching as states implement these provisions in the coming years. Of course, policy is not inevitable. Things can be changed, things can be revoked. So keeping an eye on how everything is developing in the state is really important. We also know that these policy changes are not going to just be like isolated to, for example, the Medicaid expansion population, even if they are a more direct target of some provisions than, say, the Medicaid program writ large. I also want to be thinking about that broader healthcare infrastructure, our providers, our workforce, et cetera. And then the last piece is just thinking about states and how they respond to mitigate the negative impacts of implementing these provisions. I've highlighted some of those pieces already, but I would want to continue to highlight the burdens that will be on the state and county groups that are processing all of these new requirements. They're implementing these new verification systems and everything, which is going to be kind of a big task to be done in the coming years. And also, again, like just that threat to our broader healthcare system and all of the groups that need healthcare and are trying to achieve optimal health here in Ohio. So just a few slides that just have QR codes. This is all on our website, so don't feel like you need to catch it right here. Our Federal Health Policy Impact in Ohio series focuses on the changes to Medicaid financing in Ohio, which also has a 4-page summary if you don't need all the nitty-gritty detail. We also have an explainer on SNAP and the Rural Health Transformation Program. We have our Healthcare Access and Affordability series, which Amy shared a lot of work from. And then Amy already did a very nice job explaining the health value dashboard, so I won't explain that again. I will highlight we also do a lot of disaggregation of data across different groups in Ohio, so you can see how Ohioans are doing on many of these metrics across race, income, education, disability status, and more. So that's another resource to look at, especially in that data book of the health value dashboard. So our contact information is here. I've left like 9-ish minutes for questions. It's a little shorter than I had hoped for, but I would love to hear what you're thinking about. Please come up and talk to us if you do have more questions. And our emails are there, so we really love to just hear what you are all thinking about, especially from that county board perspective. And thank you for taking all this in. I know it's a lot of information.
Thanks, Brian. Jake and I both have microphones. Would love to get some questions from county level folks on how they see some of this trickling down. You must see something I don't.
Yep.
Jake?
Got one back here.
Well, we deeply appreciate the overview. Thank you very much. The hospital franchise fee went to the rate increase, and I think it was about $70 million. How does that look for 2027, or is that too far in the weeds for your presentation today?
That's a good question. I don't know exactly what it looks like going forward. I know that last minute increase before HR 1 passed, essentially it was a compromise between hospitals and the governor's office to essentially use, I think it's about 40% of the additional revenue that's now coming in towards the governor's priorities. And one of those priorities was just to continue to support those rate increases going forward. Now, how exactly that shakes out, once the phase down starts, I think we don't have the answers on, but because some of that money is directly going towards those HCBS rate increases, I think it's a good one to keep your eye on, especially in the next gubernatorial administration.
I think there may be a question from virtual audience. Not yet.
Not yet.
Okay. Other questions for Brian and Amy?
Right here.
how do we know if an individual is enrolled in Group 8 Medicaid, and how can we assist them either transition to regular Medicaid or help them through the process?
So I've learned a little more about that in recent months. So I'll share with you what I've learned. But if you wouldn't mind giving me your contact information, I can follow up. So there's an initiative called the Eligibility Management Initiative that's been started by a couple of people slash organizations who they're more focused right now on people with mental health and substance use disorder, and making sure that providers get these reports that Medicaid can provide that show what eligibility category people are actually in. Because a lot of times, like, providers don't know, boards don't know. So the purpose of that whole initiative is to build a system that can easily problem solve and smooth some of these potential transition bumps for people who likely are still going to be eligible for coverage going forward, just are not in the right category. So Rick Tully is the person, one of the people that's kind of leading on this. He used to work with Monica. He's a longtime state government employee, worked at Medicaid, worked in a bunch of other state agencies. And he knows the nuances of Medicaid eligibility and like all of these reports and all of this more than I think anyone in the state knows. So I'd love to follow up with him to get more information and convey that to you. And we can continue to be in conversation with the County Board Association too, to see if there's a way in which your system can participate in that initiative and somehow get access to those reports as well.
Christine,
Have you heard about some of these Medicaid bills that was in the Ohio House Medicaid? They are really taking a look at trying to put a single entrance for and eliminating this managed care and getting everything to be going like to this straight window eligibility for everything. I can also say for anyone in here, if somebody gets out of the Group 8 but they work checking the Medicaid buy-in, but still we are we're concerned that also parents of minors, okay, we're only hearing these rumors, okay, that parents of minors not being allowed to work and be paid, even family members of children with complex medical needs. That's another message out there that we will have to figure out, because the last thing we don't want to see is the parent having to give up custody and put them in the institution or to get help is the last thing we want.
Thank you for your questions. I'm going to talk about the last question first, and then Brian can share more information too. Yes, there is just really this week, there's been a greater focus on concerns around family caregivers who are paid to provide homemaker personal care services to people who have waivers. And this one kind of gets me emotional. So, because we know that people who have relatively higher incomes, like this is, or maybe it's a two-person family, like two-parent family with one person earning enough that the other person can stay home and care for a loved one. That's a luxury that not many people within the state of Ohio have. And so allowing Medicaid reimbursement for caregivers to provide those services is really important for leveling the playing field for all families to be able to do that and honor the personal wishes of the person who would rather get care from a family member or close friend than a stranger coming into their house. So exactly, and prevent the workforce crisis from being even worse than it is. So definitely an important issue for you all to communicate with your elected officials about, because I think it's very seriously at risk right now. We're contemplating what HPIO could put out that could be helpful and from a data perspective and evidence perspective on this. But hearing directly from people is equally, if not more important, than any kind of data or analysis that we could put out. So would urge you to be involved in that. And you want to add?
Yeah, I think that was really well said. I think it's a really important thing to keep an eye on because there's just so much conversation about that happening right now in the State House. I think elevating the importance of family givers from that workforce perspective, from how valuable it can be for people who need care in the home. There were a lot of things said during that Medicaid testimony that you had referenced that were, a little bit hard to listen to and I think can be pushed back against, including someone who came after the person from the Daily Wire at that testimony who really talked about their experience getting services in the home and not having to go to an institution. So I do think everything Amy said there is really valuable and something we're going to be potentially putting work on out specifically in the coming, hopefully, like few weeks. And then related to your first question, just quickly, we had seen that there was legislation to move away from Medicaid managed care. It is, getting a lot of talk. We've seen it in media. We've been asked by a couple of media sources to talk about it. I think right now it's just keeping an eye on how how that legislation progresses. That would obviously have major changes for how, eligibility is determined. But you could see, for example, efficiencies from, everything going through one singular organization. I think there's a lot of right now momentum towards looking for solutions to bring down some of that administrative waste or administrative burden because, that is just more costs to the state. And that's an area of savings that is definitely less painful than cutting Medicaid expenditures, for example, or cutting Medicaid services.
Yeah, administrative service organization model is what's being discussed.
All right. Before we break, we just have one quick question from the chat. The 6-month redeterminations for the is that for the expansion groups only or all recipients?
Expansion groups only.
For the 6-month.
For the 6-month redetermination, yes.
Awesome. Thank you.